I would like to thank Dr. Hansana for the kind invitation, and also thanks for Chairperson, Professor Sam Hanafi, my professor, Professor Hassan, Professor Sham, for their kind presence here, and thank all of you to be till now here. I know it's very, very, very long day. The problem that I have 2 lectures now, so I will try to make it as less as possible. In fact, for Botox in 2017, just to say that it could be the wonder drug common drug from the penis. We know all for male sexual disorder that it can happen in any part of the cycle, especially in erection or in the ejaculation. I cannot see it here for women. I cannot see it here, the slide. The special erection, it's the consistent inability or recurrent inability to man to attain or to maintain is erection sufficient for sexual intercourse for both of them in 50% of their intercourse. It cannot happen once or twice and we say that we have an erectile dysfunction. According to Massachusetts male aging study, it shows that 52% of male above 40 are suffering of erectile dysfunction. And in other studies, 10,000 male have been interviewed through the phone. The responders was 3,124 was responding by the phone, showing that 40% of male above 40 have a problem of erectile dysfunction. It could be a psychogenic cause, it could be an organic cause, but mainly it is a mixed cause between both of them. It could be a sign of an underlying problem like diabetes or hypertension, so it could be a first sign for a big problem. Still 64% of patients that suffering from erectile dysfunction show one or more of these comorbidities, like they have a diabetes with this and they have hypertension. So 64 have a comorbidity, especially if they are above 40. Also, it could be a sign for a serious condition like a cardiovascular problem. And that was a study in 2010 which have been published that some of the patients are atherogenic erectile dysfunction above 40, showing serious coronary insufficiency after 3 to 4 years from erectile dysfunction, because this terminal artery could be a sign for an uncommon bigger artery and uncommon bigger artery. So if you have a patient with atherogenic erectile dysfunction above 40, you should ask the cardiologist for stress test and for echo to be sure that the patients will not suffer in the future from a coronary problem. And as you can see here, electron microscopically, the difference between the healthy endothelium as well as that of the atherosclerotic endothelium between both, and the difference is very obvious. There is many major risk factors beyond the erectile dysfunctions, like age is the first one, unhealthy lifestyle, alcohol or smoking or stress, chronic diseases like hypertension, diabetes, as well as a list of drugs can be cause of the problem like this list. And of course, the diabetes and other comorbidities, there is more falls than the normal. So as you can see here in diabetes, they are suffering 4 times more than the normal for having an erectile. There is a risk of having erectile dysfunction 4 times than the normal humans, healthy. The diagnosis depends on the history, of course, a very focused history. Some examinations, some lab tested, specifically like Doppler or testosterone hormones. This is the list of sexual history and medical history that you should ask your patient about it. You are using questionnaires which usually used to evaluate the erections, like the IEF, sexual inventory, or SHAM-PEN, or global assessment profile. Also, the erection hardness score is the easiest one. Just 1 or 2 sample questions for 4 scales. 0, the penis is not enlarged, and 4, the penis is completely enlarged. So you can ask your patient 1 single question and you can see the difference. Physical examinations should be completed 1. And the management guidelines, depending first on treating the underlying major risk factors, ask the patient for healthy life. And there was another published paper in 2010 in Milano was published that if you practice as an exercise 5 hours per week for continuously 3 months, there is a great difference in the IEF score only by sport, not any other things, only by sport. So the healthy life make a big difference. If not, we go into the oral agents, especially the PDE5 inhibitors, as we all know. If not, we go to other PDE5 or others oral treatments. If it is not responding, locally we work in the organ itself by injection before we are using the Bavrine and the problem of priapism, then the quadri, dry, then the BGE, and after that we are using difference, and we're talking about it, so the PRP, the botox and stem cell. I'm going rapidly because I'm not in the main points of speaking, just general information about it. If no response, we go to surgery. But now before surgery, there is a new era, and this is the era of the PRP, the botox, the stem cells, and also are coming like the spider beam even. And we know that erections can be caused by thinking centrally or peripherally from the organ itself. And the idea here that the lacunar sinusoids dilated from the flaccid, which is in the vasoconstriction, to become dilated in the erection. And here is the photo for the lacunar space itself. If you can see here the trabecular smooth muscle. If you can see here the trabecular smooth muscle, in the flaccid state, and giving the circulation coming from the artery and go from the venule to continuously making the flow in the flaccid state. In erection, there is relaxation for these trabecular smooth muscles, ending by erection. And here, botox work. When we inject it, it makes the trabecular smooth muscle relax because the innervation, which is normally in the vasoconstriction, becoming a vasodilatation. That's why the patients after the injection, he feel even in the flaccid, his penile becomes more flaccid, more longer, not because it's become more longer, but because it's full of blood. That's why no need for more nitric oxide, no need for more desire, no need for more stress of like he facing when he have a full flaccid state. And here work the botox. And we are talking about botox even for our patients who was already scheduled for penile prosthesis. There is many neurotransmitters involved in the form of vaginismus, especially noradrenaline. Others are involved in the erection, acetylcholine, nitric oxide, and vasoactive intestinal polypeptide. The management strategy, either it is working centrally in the brain or peripherally in the penile tissue itself. Either it is an initiator, no need for a stimulus, or conditioner, we need a stimulus to work. And there is multi of treatments working in the neurotransmitters. Either we stop the decunescence or we increase the relaxations, as we said before. And the oral therapy, usually it is an adrenergic receptor antagonist, but nowadays we are not using it because it's side effect. Dopamine receptor agonist, also we don't use it because of nausea and vomiting that causing in the previously, serotonin receptor agonist. Nitric oxide clone like arginine, which is not so efficient. Phosphodiesterase PDE5 inhibitors, and we all know about it. The sildenafil, tadalafil, and verdenafil. Tadalafil gives you freedom in any time you can have the sex. The sildenafil the hardest, and the verdenafil is the safest one. If you compare between them, not so deep. Locally, we inject intracavernosal injection, and even before we use intraurethral like Muse, but it was painful. Nowadays there is a vitreous gel making the same effects and not painful, and it is available in the market and giving a very, very, very powerful effect for some cases. Topical agents, as we say, Vitus, shot, which is the BRB, and botox, and we are going to talk about it, and the future for the gene therapy. This is the adrenergic receptor antagonist. You cannot use it in hypertension. Phentolamine, it causing a side effect even in animals, and we don't use the serotonin. Now, one of the available medications in the market for erectile dysfunctions is a medicine that working in the melanocortin receptor, which is a melanocortin receptor agonist. It's called bremelanotide. And by a study in 25 males who are not responding to 100 milligram of sildenafil, they show that all of them are improved by using this drug, and it is available in the market. In the level of the cellular level, we speak about the BDE5 inhibitors. And we know where it works, and we know the difference between the three of them, and this is not the main issue here. The intracorporeal injection, it was the Bavarin, then the Trimex. Nowadays, which is available is the Indicor, which is a BRD and phentolamine, same as prostaglandin but without pain. When you are injecting anything intracorporeally, BRD or botox or any drugs, you have to be sure that you are intrasinusoidal. So you have to be sure that when you aspirate, there is a blood in the needle, so that you are sure you are not touching the intrasinusoidal or intraseptal that may cause inflammation in by pyonesis or fibrosis later on. If not responding, what we are going to usually do in the past, we do go to surgery. But nowadays, there is a new concept, which is the botox, functional electric stimulations, gene therapy, melanocortin receptor agonist, we speak about it, PRP or B-shot, shockwave therapy, spider venom and stem cell therapy, thermal activated benign implant, and some topical drugs. For the spider venom, it has been discovered in Brazil, which is called Brazilian banana spider venom. They found that the patients, when they are having the spider insects, they die. It's toxic. They die, end by die. But they found that before they die, they have an erection for 4 hours. And that's why before, and then they die. Erection, then they die. It's cool, but the discovery now working in the animal. They are trying to separate the toxic elements. It's just a spider. They found that a spider within the banana, called the Brazilian spider banana, that end by death, and before death, they have a good erection for 4 hours. So the scientists started to take the toxic from the spider and try to see what's going on in the future. It's still an animal, of course. Nobody will do that to die for 4 hours. For the BRP, according to the male sexual reproductive, they say that we don't have enough data for the BRP injection in male. Especially, we don't have a huge number of patients that we do research on them in the BRP. So it is effective, as they say, and it is good tool to be used in male and not hazardous, because there is no side effects unless there is some pain according to the kind of plasma separation that you are using. But all the studies show that the PRP is good an erection tool for male genital dysfunction. One of the biggest studies is in the 60 male injection of PRP, and most of them, even 92%, show that they are satisfied with the global assessment profile. The B-shots, the idea here that you are using immediately the vacuum after the injection, so that you make a distribution in the cavernous tissue, same distributions is becoming equal, and you make a minute trauma. This minute trauma enhances the platelets to increase the level of cytokines and growth factors leading to internal rejuvenation in the cavernous tissue. And that's why the vacuum is worked, and that's why after the injection, it's better to use a vacuum, either it's PRP or other intracorporeal injection. Stem cells, it's an evidence that it works very good, either it is an adipose or a bone marrow, and there is a many study about injection and the way to inject for the bone marrow. The well-known PRP is the Magellan PRP. For the adipose, we do it in a nanofat plus some of the stem cell PRP as a mix before we inject it. The thermal activated benign implant, as you can see, it is tilted in the temperature, which is cold, but with heating it becomes fixed and strength. That's why when it was used around the benign prosthesis, during the normal life it is flaccid. With the heatness in the cavernous tissue in the foreplay, it becomes more stressed until it becomes full erections, so that it gives them the feel of natural erection. Of course, it's not natural, but they try to make it more natural by the benign prosthesis, by this system. Shockwave, they say that it increases the blood vasculatures. And now for the Botox, there is many studies about that. One of the studies is have been published, divided the three groups into control group, 1 milli of saline, 50 units in the other group, 100 units in the third group, and the result was very significant in the global assessment profile, as well as in the sexual encounter profile, as well as in the erection hardness score. Another study done by Dr. Hussein Ghanem, in 24, 12 of them was controlled, and 12 of them was injecting Botox. He injected the two sides of the cavernous tissue, 25, 25, direct pressure for 2 minutes, and after that 25 minutes to repeat. The result was marvelous. As you can see, the difference between the control grade 1 and the Botox injection, the blue one in the sexual encounter profile, as well as in the global assessment questionnaire. And you have to know that this patient was a candidate for benign prosthesis. So they are going for a benign prosthesis. So before benign prosthesis, you try this trial and you have this nice result. So you avoid the benign prosthesis by trying the Botox injection for them. And I do the same in a 48 patients candidate who was already ready for the benign prosthesis. 24 was controlled and 24 received the intracorporeal injection of Botox, 50 unit, 25 in each side. Dr. Ahmed Salem, when he speak today, he tell me, why you don't do it in one shot? And he is right, because it's go to both sides, maybe to save time. After that, I make a control groups, only 1 milli saline. But I found that two of the control groups say that they feel something which gives us a significant improvement, that the psychogenic elements make a big role in even if you are a candidate for benign prosthesis. And the 14 candidates from the 24 which are injected by Botox show that the result was up to 73% of them saying that they are satisfied. Even the female partners, I'm using the vacuum, like the B shots. Usually, they use the Botox in all the study without the vacuum, but I use the vacuum because of the same concept we talk about it, and this gives me a better results. And even I use after it a PRP when the patient is not responding to Botox alone, and I found 2 patients before they was not responding to PRP alone. After I inject Botox with PRP, it's becoming very significantly responding for results. The results suggest a possible benefit of the intracavernosal Botox in the treatment of patients with severe refractory erectile dysfunction, and lead to a reduction in the number of patients requiring penile implant surgery, and this is the genes which they are working with. There will be a diploma in male genital enhancement if you would like to join us in Abu Dhabi. Also, I would like to see all of you in Abu Dhabi for our upcoming events, the 6th Abu Dhabi International Derma Conference in 10 to 12 September 2020. And thank you, and I'm in time.